Welcome back to this next video in which we are discussing valvular heart disease. Okay, so we're going into a new phase of this video. We're now going to start discussing the actual pathological processes that can cause any of the four heart valves to become diseased, so either stenotic or regurgitating. And as I said right at the beginning of the video, we're going to go through 6 separate pathological processes, and we're going to begin with the absolutely most common one to occur, which is calcification. So I think we'll do this in this space here. So I'll just zoom in a little bit, and then we'll start it here. Okay, so calcification is the first pathological process that we are going to go over. So, just interpreting the word then, the cusps of a valve are going to become calcified in this pathological process. So calcium is going to get deposited there. Now generally where calcium gets deposited, that leads to that tissue becoming harder. So calcification of the cusps of a heart valve is going to lead to those cusps becoming harder. And if they become harder, they're going to become less motile, and that means that they're not going to open as effectively. So calcification of one of the heart valves is going to lead to the stenosis of that heart valve. So calcification leads to stenosis, because if the heart valves are less motile, then they're not going to be able to open as well. They're not going to be able to move as far apart and open up as larger gaps. So you're going to get you're going to get stenosis of that heart valve. Now, in principle, this pathological process, calcification, can affect any one of the 4 heart valves. So you could get tricuspid valve being affected, where its cusps become calcified, and that could be a cause of tricuspid stenosis. You could get it affecting the pulmonary valves. You could get pulmonary valve calcification and therefore pulmonary stenosis. You can get mitral calcification and also aortic calcification. Now, that's in principle. In practice, you very, very rarely see tricuspid valve calcification or pulmonary valve calcification. By far, it's far more common to have the left heart valves affected by the calcification process, and you'll understand that when we discuss the pathogenesis process in a bit. Okay, so the major heart valve then that is affected by calcification is the aortic valve. And indeed, aortic stenosis due to calcification, called calcific aortic stenosis, is the most common form of valvular heart disease, full stop. So calcific aortic stenosis. So what happens is the cusps of the aortic valve become calcified, and that leads to them no longer being very motile, and therefore they don't open properly, and therefore you get aortic stenosis, and that's going to have serious consequences for the left ventricle's ability to pump blood into the aorta. So that by far is the most common form of calcific heart disease affecting the aorta. To a lesser extent, you occasionally see people who have had calcification affect the mitral valve. So sometimes you can see mitral valve cusp calcification and therefore mitral stenosis as a result of the calcification, but that's rarer than the aortic calcification process. And as I say, the right heart valves, in principle it can happen. In practice, you'll never actually see someone who has got a calcified tricuspid or pulmonary valve. Okay, so the question that we now need to answer then is, why does this calcification process primarily affect the left heart valves? Well, the pathological process is actually believed to be almost identical to atherosclerosis at our current level of understanding, and it may fall apart from atherosclerosis later on as we find out more about it, but at the moment our current understanding is that effectively this calcification process is just atherosclerosis occurring, instead of in the wall of an artery, in the wall of the valve cusp. So I'll just jot that down. And the starting point for atherosclerosis, if you remember your pathogenesis of atherosclerosis, is chronic endothelial cell injury. And generally this is because of the blood pushing against the endothelial cells, so the pressure of the blood damaging the endothelial cells. And the left heart has far higher pressures of blood inside it, so the left heart valves are going to be exposed to much higher pressures of blood than the right heart valves, which is why calcification primarily affects the left heart valves in practice rather than the right heart valves. So, pathogenesis then is extremely similar to atherosclerosis. At our current understanding, it's identical pretty much to atherosclerosis. So pathogenesis is very similar to atherosclerosis. So if you are familiar with your pathogenesis of atherosclerosis, then the discussion that's about to follow should just be revision, and you can go, oh wow, okay, so let's now go through the actual pathogenesis process then. And as I say, this is going to just be the pathogenesis of atherosclerosis. So let me begin by drawing some endothelial cells then. So here's one endothelial cell, and here's another endothelial cell. And these are going to be endothelial cells sitting on the surface of the valve cusp. So remember, if we're talking about any one of the heart valves, so we might as well take the aortic valve because this process is by far the most common in the aortic valve. So if we've got the aortic valve and we go to one of the three cusps, those cusps are covered by endothelial cells, and fundamentally this process is believed to start with the endothelial cells, just like atherosclerosis is believed to start with the endothelial cells. Okay, so let me put the endothelial cells sitting on the basement membrane then, and then we'll go from there. Okay, there we go. Right, so the process then is believed to begin with chronic injury to the endothelial cells. So this is because of the blood pushing up against them. So I'll mark this on like so. So the endothelial cells are going to get chronic strain, I'll say. I'll put chronic injury. So the endothelial cells are being chronically injured and having signaling pathways activated within them that are in accordance with them being injured by the blood that is pushing up against them. So they get chronically injured, and what is the response of an endothelial cell to being chronically injured? Well, think about it from the endothelial cell's point of view. If you're being continuously injured, what do you interpret that to mean? You interpret it to mean that there is something that is damaging you, okay? And one of the nasty things that can damage cells is pathogens. So the endothelial cells seem to respond as though they are being damaged by a pathogen, and potentially as we grow to understand the pathogenesis of atherosclerosis and the pathogenesis of calcification of the heart valves more, it might turn out that there actually is a pathogen present that is damaging the endothelial cells. However, at present we don't believe that is the case. We believe it is things in the blood that are damaging the endothelial cells, particularly the pressure of the blood pressing up against the endothelial cells. However, the endothelial cells certainly react in the same way that they would if there was a pathogen present that was attacking them. And they initiate effectively the inflammatory response. They undergo endothelial cell contraction and they start recruiting white blood cells into the connective tissue underneath them. So, let me write this down. So these endothelial cells are now going to do two things. One of those things is endothelial cell contraction. So what does endothelial cell contraction mean? This means that the endothelial cells are going to reduce down their size, and this opens up gaps between the endothelial cells. So let me show this by showing the new position of the endothelial cells. So they're going to change their shape. They're going to pull in their peripheries. They're going to get thinner effectively. So the white outline is where the endothelial cell was previously, its previous shape. The blue outline is its new shape after it's undergone this contraction process. And here's the neighbouring one undergoing the same process. So you can see they've become smaller. They've pulled back their peripheries. And what's the purpose of this? It opens up gaps between the endothelial cells. Previously, the endothelial cells were forming a nice seal. Okay, you could not cross the endothelium without going through an endothelial cell, or at least it was very difficult to get through that gap between the two endothelial cells. Now they've pulled themselves apart from each other, and there's a nice big gap here, and that's going to allow things in the blood fluid and proteins within the blood, but not cells on their own, not without help, to move through this gap into the tissue underneath. And that fluid with proteins and other things from the blood that comes into the underlying tissue is known as an exudate, so you get an exudate produced. Now, what's the purpose of this? Well, remember, in the blood there are all sorts of proteins, for instance the complement proteins, put in there by the liver that are extremely good at destroying pathogens. So you're recruiting part of the innate immune system here. These endothelial cells are determined that there is something underneath them doing horrible damage to them that is causing these signaling pathways telling them that they've been injured. So they've pulled themselves apart to allow in exudate that will hopefully destroy those pathogens. Okay, so that's endothelial cell contraction, and we'll come back to this because this is going to allow in LDL, so we'll come back to that later on. And then the other thing they do is they start recruiting leukocytes, white blood cells. So leukocytes, leuko means white, cyte means cell, so these are white blood cells. So leukocyte recruitment. So they're going to recruit white blood cells from the blood into the underlying connective tissue. Okay, now they've opened up nice gaps, and these gaps are indeed gaps that the white blood cells are going to move through, but they can't just go through on their own. It's not quite that easy to get through this gap. It's not quite wide enough for them just to slip through there. They need a lot of assistance from the neighbouring endothelial cells, and they really do have to squeeze through that gap in the process known as diapedesis, and they end up changing their shape hugely. They have to sliver into a sausage, basically, and sliver through. And I'll just write down what I said there. That's a process called diapedesis. Now, in order for the endothelial cells, and let me just spell diapedesis right first, so diapedesis. So in order for the endothelial cells to help white blood cells move through these gaps, then they have to bind proteins on their surface to proteins on the surface of the white blood cells. So, in order to recruit white blood cells, the endothelial cells, as part of their reaction to the chronic injury, are going to put on their surface proteins to bind to proteins on the surface of the white blood cell. And one of the key ones that they're going to put on their surface, I mean there's loads that they'll put on, but one of the key ones to know is that they put on VCAM1. VCAM1. And this stands for vascular cell adhesion molecule 1. So the V is for vascular, and then whenever you see CAM in biology, it usually means cell adhesion molecule. There are loads of different cell adhesion molecules. So this is VCAM1, vascular cell adhesion molecule 1. Okay, so the endothelial cells that have been exposed to chronic injury are now contracting, allowing an exudate to come in, and they're also putting VCAM1 on their surface, and this is now going to bind to proteins on the surface of white blood cells. So let me now draw a white blood cell. So I'll put the white blood cell here in yellow, and we'll discuss the types of white blood cell that we're going to recruit in just a moment. So here is my white blood cell at the moment, so I'll just label it up. This is a WBC for white blood cell. And on its surface, it's going to have a protein that's going to be able to bind to the VCAM1. And this protein is known as VLA4. So VLA4, standing for very late antigen 4, I believe. So I'll write this down here. So VLA4 is very late antigen 4, and it's an integrin protein, so it's a dimer of two separate proteins, well, two separate polypeptides bound together. And I can't remember the exact names. It's an alpha and a beta integrin, I believe, but I can't remember the exact numbers. I think it, no, I wouldn't like to guess. But anyway, it's a protein on the surface of the white blood cells that will bind to VCAM1, and that adheres the white blood cell to the endothelial cell, and then the white blood cell can coordinate itself, squash itself through this gap in a process known as diapedesis, and therefore get recruited into the connective tissue underneath. Okay, so let's now move on. So we're recruiting these white blood cells into the connective tissue underneath, so let's actually have some white blood cells now. And which sort of white blood cells are we actually going to recruit then? Well, there are two major types that you need to know about. One of the types is we're going to recruit T cells, effector T cells. Now, if you know your immunology, you'll know that effector T cells have a T cell receptor on their surface, and that T cell receptor is designed or is specific against a certain antigen. In fact, more than that, it's against a certain fragment of a certain antigen. So the question now is, these effector T cells that we're bringing in, are there T cell receptors directed against some fragment of some antigen that's in this connective tissue underneath? And at present, we think the answer is no. We think that you just bring in T cells at random, any old effector T cells in the bloodstream that might have been produced as part of an immune response against God only knows which pathogen that you might have been infected with recently, some virus potentially that might have caused a cold or something. The idea is that any old effector T cells that just happen to be circulating past, they're going to be brought in. So at present, we do not believe that the effector T cells that are brought in here are directed against some antigen that's underneath here. Okay, so, but that might change in the future as we understand this pathogenesis process more. So this is a effector T cell, and again, it could be CD4 or CD8, so both types of T cell. Okay, so it's an effector T cell, and we'll see the effect of these effector T cells later on. So that's one of the types of white blood cell that we're bringing in here. The other major type of white blood cell that we're going to recruit are monocytes from the blood. Now, monocytes become macrophages, so you do not have macrophages circulating in the blood. You have a precursor to a macrophage circulating in the blood called a monocyte. And they look exactly like effector T cells. So this picture that I drew here, it was valid for both the effector T cells and the monocytes. They all have this same sort of structure where they're a nice round cell with a massive great nucleus. So it was a valid picture for both effector T cells and monocytes. So the instant that you bring the monocyte into the underlying connective tissue, so once it's out of the blood, however, it will differentiate into a macrophage, and these are much bigger cells. They have much more cytoplasm, so they have a shape that looks like this now. There's their nucleus, and you can see that the ratio between their cytoplasm, or the cell size, and the nucleus is hugely increased now. You've got much more cytoplasm than you had in the case of the monocyte. So these macrophages that you've now got, of course, they're not really an ideal cell to be circulating around the blood because they're so big and blobby. It's much better to have them in a compact form, which is the monocyte. Okay, so we bring in macrophages and effector T cells into the connective tissue that's underneath the endothelium that's being chronically damaged. So, we won't discuss instantly what the effector T cells do, but I would like to now say something about what these macrophages come in and do. So, remember back to the whole motivation for this. These endothelial cells are reacting as though there is something dangerous in the connective tissue underneath them that is causing them this chronic damage. They've now succeeded in bringing in macrophages into that tissue underneath them, and this will be occurring continuously over a long period of time. Okay? Those macrophages are now going to try and attack whatever it is underneath. And one of the ways that macrophages attack pathogens is by releasing a whole bunch of poisons. And their special poisons that they like to release are reactive oxygen species. So the macrophages are now going to release a bunch of molecules that we can call reactive oxygen species, so ROS for short. So this stands for, sorry about that, dysfunction of the machine temporarily, reactive oxygen species. Okay, so these are molecules that contain oxygen and which are very, very reactive. So let me give you some examples of reactive oxygen species. So one of them is the superoxide radical, O2 minus dot. Okay, so this is superoxide. That's one very, very reactive oxygen species. I mean, it's a free radical. Free radicals are very, very reactive because they've got unpaired electrons, and electrons don't like being unpaired. Another reactive oxygen species is another free radical, the hydroxyl radical. So this is the hydroxyl radical. And then another reactive oxygen species is hydrogen peroxide, which is H2O2. So water with an extra oxygen. So this is hydrogen peroxide. And these are not nice molecules in biology. They're horrible molecules in biology. They're incredibly reactive. They can react with pretty much all of the biological macromolecules. So they can react with great big lipids. They can react with great big carbohydrates. They can react with great big proteins. And scarily, they can react with great big nucleic acid molecules like DNA and RNA. So cells do not like these molecules because they tend to do a lot of damage to cells. Now this is exactly why the macrophages are spitting these things out. They are under the impression that there is some foulity in this connective tissue that they have come into, and they are deciding to poison that species, to destroy it with these incredibly reactive chemical molecules. Okay, so that's the bit of the pathogenesis that we've got up to now. We've brought in these macrophages and they're spitting out reactive oxygen species. We now need to take a step back and talk about the fact that the endothelial cell contraction is going to bring in something else into this sub-endothelial connective tissue here, the valve cusp connective tissue. And that's LDL. So we now need to introduce LDL in this story. So I'll go on to orange for this. So through this gap between the endothelial cells, and this isn't brought in by the endothelial cells, this is just going to come through the gap. So unlike the leukocytes, this isn't invited in, it just comes in, is going to come particles in the blood known as LDL particles. And LDL stands for low density lipoprotein particles. Now, what are these things? These are little balls that carry lipid around the bloodstream. So lipid molecules are extremely hydrophobic, so they have to assemble into these clever structures to actually be transported around the bloodstream and be soluble inside the bloodstream. And low density lipoprotein is one such structure. There are many different lipoproteins, which are these structures that carry lipids around the bloodstream. Low density lipoprotein is famous because it is the major carrier of lipid cholesterol. So let me now just draw you a little picture of what a low density lipoprotein actually looks like. So it has an outer lipid monolayer, phospholipid monolayer, with a massive protein in it known as apolipoprotein B100, and then it has a core that is full of cholesterol esters. So it's a little ball fundamentally. When you look at an LDL particle, it's a tiny little ball. I think it's around 20 nanometers in diameter. And the outer layer of the sphere is made up of phospholipids, and it's not a phospholipid bilayer like you'd have around cells. It's a phospholipid monolayer. So let me try and draw a few of these. So let me zoom in on my picture of LDL here. So you remember the basic way of drawing a phospholipid. You draw it like so, with the two hydrophobic tails there and the polar head at the top. So I'm just going over this ball here. This is the polar head of the phospholipid. This is where the phosphate group is, and then these are the long chain carboxylic acids, the fatty acids of the phospholipid, hence why it's called phospholipid. It's got a phosphate group and then lipid components, and it always has two lipid components and one phosphate group. And those are very hydrophobic. So you're going to have the polar groups facing out. So hopefully you can start to see why this is actually a clever design, because we're going to have these polar groups, the phosphate groups, facing the outer world where the water is. Okay, so those are going to nicely interact with the water, and these hydrophobic groups, they're going to face into the core where we're going to stick loads of really hydrophobic molecules. Okay, so in green here, these are phospholipids, and there is a very famous phospholipid that is the major one that's going to be used in this phospholipid monolayer here. And by the way, this is what's known as a phospholipid monolayer. So remember, around cells you have a phospholipid bilayer, which consists of two layers of phospholipids. This only consists of a single layer of phospholipids, and therefore is called a phospholipid monolayer. Okay, so the major phospholipid that you will use in this phospholipid monolayer, and which is the major phospholipid in phospholipid bilayers of cell membranes as well, is a phospholipid known as lecithin. And this has another name. It's also called phosphatidylcholine. Now, phosphatidyl, that prefix basically just tells you it's a phospholipid. It refers to the fact that you've got two hydrophobic tails and a phosphate group bound together by glycerol. And then the choline tells you that you've stuck, in addition to that, you've stuck a choline molecule, the same choline that's in acetylcholine, onto the phosphate head. So on the phosphate head, you've stuck on a choline molecule, but we'll still just draw it in this basic way like this. So that's the major phospholipid that's used in the phospholipid monolayer of LDL, and indeed in the phospholipid bilayer of cells. Okay, so you create this sphere then, where the outer layer is going to be a phospholipid monolayer, and in that phospholipid monolayer there is a massive great protein that dominates it, and I'll have it being all of this. So implanted in the phospholipid monolayer, there is a massive great protein that every single LDL particle has. Each LDL particle has one protein, and it's always this protein. And this protein is known as apolipoprotein B100. And for short, you can write that like so, apolipoprotein B100. And I think I've written that actually wrong. I think I've put the dash in the wrong place. I think actually the conventional way of writing it is apo-B and then the 100 like that, rather than apo/B100. I think that's better. Okay, so the full name for this is apolipoprotein, which just means the protein component of the lipoprotein. So fundamentally, a lipoprotein is called a lipoprotein because it's this ball consisting of lipid and protein, and this is the protein component, and that's apolipoprotein B100, because there are lots of different apolipoproteins, and in the different lipoproteins, so for instance HDL, VLDL, chylomicrons, IDL, these are other examples of lipoproteins. And you have other apolipoproteins other than just apolipoprotein B100. In LDL particles, you just have this one copy of this protein for each LDL particle, no more proteins. Okay, right. So now let's talk about the cholesterol, because so far we've seen a protein and phospholipids, but these particles are famous because of cholesterol. Where's the cholesterol? Well, there are two forms that cholesterol is carried in LDL particles. One is just as free cholesterol, so the actual cholesterol molecules themselves. Now, cholesterol is a sterol molecule. It's a steroid with an alcohol group attached onto the onto the steroid structure. Now, that means that cholesterol has one glimpse of polarity. It actually has that alcohol group. It does have an alcohol group, that's the ol at the end. And that gives it a tiny little bit of polarity. So the rest of the molecule is completely hydrophobic, but it does have one little bit that's polar. And that actually means that cholesterol can sit in this phospholipid monolayer as long as the polar alcohol group is facing the outside where the water is. So this little dot that I put here, this is the alcohol group of the cholesterol. The rest of the cholesterol molecule is extremely hydrophobic, and it has to face the middle, therefore. So you do actually have cholesterol molecules with the lecithin molecules in the phospholipid monolayer here. The other form that cholesterol is in these LDL particles is as cholesterol esters, and these are not polar whatsoever. They don't even have a single glimpse of polarity, because when you create a cholesterol ester, what you do is you take the one alcohol group of cholesterol and you take a long-chain carboxylic acid, a fatty acid, and you esterify the two together. You bind a long-chain carboxylic acid onto that alcohol group, and that gets rid of that polarity. It turns the molecule into a completely hydrophobic molecule. So cholesterol esters are not polar whatsoever. They cannot sit in the phospholipid monolayer, so they have to sit in the core here, and I'll draw them like so. So here's the cholesterol, and here then is the fatty acid that's bound to it. So this is representing a cholesterol ester. So LDL particles then, the basic structure, or the scaffold structures, if you like, is the apolipoprotein B100 and then the phospholipid monolayer. The actual cargo is the cholesterol molecules in the phospholipid monolayer, and then the lots of cholesterol ester molecules in the core of the LDL particle. So this bit we will call the core of the LDL particle. Right. Okay, so that's a little bit of a revision about what LDL is. And these particles are in the blood and they are the main carrier of cholesterol. Okay, so you have lots of these particles in the blood carrying cholesterol. And unfortunately now, when the endothelial cells contract, that's going to allow LDL particles from the blood to come into this connective tissue. And now let's go back to the reactive oxygen species. So, to summarise where we've got to so far, we brought in macrophages, monocytes, and LDL particles, and the macrophages have released these horrible poisonous molecules, these reactive oxygen species. Now, the reactive oxygen species, I told you they will react with any biological molecule you give them. They're going to react with the low-density lipoproteins, and they change these low-density lipoprotein particles in some way that we do not actually understand really at all. They react with them, and what you get, we then call oxidized LDL. What has actually changed, we do not understand, but something has changed, and these oxidized LDL particles have very different properties. So, what happens is these two things are going to come together, and you're going to end up with new particles called oxidized LDL particles, which we write as OxLDL. So this stands for oxidized LDL. Okay, so as I say, we do not actually understand the nature of oxidized LDL. I cannot tell you what has actually changed. You've thrown loads of these molecules at this, they've reacted with probably everything, and they completely changed the property of the LDL particle, and we now call that LDL particle an oxidized LDL particle, and these are now extremely dangerous and they're extremely important in the pathological process here. Okay, so oxidized LDL by definition is just LDL that has reacted with all of these reactive oxygen species. That's the definition of it. We do not actually know what the chemical nature of it and which lipids have reacted with this and which ones are significant that have reacted with this for the properties of this biologically. Okay, but I'm now going to tell you what oxidized LDL actually does. So oxidized LDL is perceived as very, very bad by these macrophages. So the macrophages which release the reactive oxygen species, they now don't like the consequences of it. They don't like the oxidized LDL, and they start uptaking it using a receptor known as the scavenger receptor B1. So on their surface, they have this receptor. Okay, and this receptor is going to uptake the oxidized LDL, so I'm wondering where to actually, I'll zoom in and put it next to it. Okay, so here we go. So this is the scavenger receptor B1, and for short that's written SRB1. So I'll now write its full name out larger down here. So that is the scavenger receptor B1 on the surface of the macrophages. Now, it's not understood how the scavenger receptor B1 actually results in the macrophage uptaking the oxidized LDL, but it doesn't seem to be an endocytosis process, unlike the LDL receptor. So if you remember back to studying Brown and Goldstein and familial hypercholesterolemia and all of that, the LDL receptor on the surface of liver cells, for instance, or on the surface of other peripheral cells in the body that need cholesterol, it binds to LDL, it binds to, I believe, the apolipoprotein B100, and then the whole particle is endocytosed inside the cell. The scavenger receptor B1 doesn't seem to do that, but we don't really understand what it does instead. But what does happen is that all the stuff inside the oxidized LDL particle ends up inside the macrophage. And that results in the macrophages turning into what we call foam cells. So they end up with these large stores of lipid inside of them, and they now look quite foamy under a microscope, and hence they are called foam cells. So now, let me get the pen back. The macrophage is going to become a foam cell, and I'll draw this foam cell here. So what you're going to end up with is, here is the nucleus still, and you're going to end up with stores of lipid inside here. So here is a store of lipid, in orange here. Here's another store of lipid, and this is all the lipid that they've absorbed by taking up oxidized LDL particles. Here's another store of lipid, and they end up looking foamy when you look at them in histological slides. And I believe that's because when you fix the tissue, all of the lipids that's actually inside the cell get washed away, so you end up just seeing sort of cloudy appearances because you see nothing anymore. The lipids have gone, so you just see white. So you see it sort of cloudy, so it does sort of look foamy. So this cell is called a foam cell. Okay, so macrophages start converting into foam cells. So this is what's going to be happening in the valve cusp then. We're going to be gradually over a long period of time, and I want to stress this is not a short-term pathological process. This is a chronic, insidious pathological process. So over a long period of time, you're going to be getting more and more of these foam cells being formed, because with the chronic injury, the endothelial cells will be bringing in more macrophages, more effector T cells, although we haven't seen what they do yet. We'll come back to them. More LDL will be coming in, and the macrophages will continuously be releasing the reactive oxygen species. You'll be getting the LDL converted into oxidized LDL, and of course, you'll then get the macrophages uptaking that and becoming foam cells. So you'll gradually accumulate more and more foam cells, and this produces the lipid component of the lesion that you're going to get in this calcification process. Now, of course, we haven't seen any calcium yet. That will come later on. So the lesion in the valve cusp is going to start with a lipid lesion, a lipid core, just like in atherosclerosis. And indeed, in atherosclerosis, you can get calcification of the lesions there as well. So indeed, this pathological process that I'm describing, it is exactly what I'd be doing if I was making a video on atherosclerosis. So let me just draw a little picture here. So let's have this as our valve cusp. And the bit that we've got to at the moment is we now have a lipid lesion here. Okay, and this is consisting of foam cells. But this, of course, is not the full story. We need more to understand this. So this is the lipid core of the calcific lesion that we're going to produce in the long term. Okay, so that's how we produce the lipid core then. We now need to talk about the production of a fibrous cap, and this is exactly the same as in atherosclerosis, and then we'll talk about the calcification of the fibrous cap. Okay, so, or the fibrous connective tissue. It's actually not going to be the fibrous cap that becomes calcified, but we'll do that when we'll cross that bridge when we get to it. Okay, so let's continue on with the pathogenesis. So now comes the part played by the effector T cells and the macrophages again. So the macrophages are completely involved, but now we're going to see what the effector T cells do. So the effector T cells and the macrophages are going to start releasing signaling molecules, and these signaling molecules are going to have an effect on the fibroblasts that are present within the different layers of the connective tissue of the valve cusp. So I'll try and motivate this. Whenever you get inflammation, whenever you bring in white blood cells to a portion of tissue, what will happen acutely is they will fight off the pathogen that is present. And remember, the endothelial cells are under the impression that there is a pathogen here, and these white cells are under the impression that there's a pathogen here because they've been brought in by the endothelial cells. So why would the endothelial cells have brought them in if there wasn't a pathogen in here? No one has realised that it is probably just the fact that the blood pressure is damaging the endothelial cells. So whenever you get white blood cells coming into a portion of tissue, they fight off the pathogen, but then they need to repair the tissue. You see, when they're fighting off the pathogen, they lead to massive tissue damage in that area. I mean, look, these macrophages are releasing these poisons. That's going to affect your tissue there as well. So after they've destroyed the pathogen, they need to then repair the tissue that they've destroyed at the same time. And therefore they release molecules that stimulate fibroblasts, which we know are cells that are involved in secreting connective tissue, to actually start secreting connective tissue and therefore produce a scar. This is how you produce a scar where you might have had a previous infective lesion. The fibroblasts will be stimulated by molecules released by white blood cells, and this is what the macrophages and the effector T cells are going to do. They're going to release molecules that will stimulate fibroblasts to start producing a scar. Okay, to replace all the tissue that was there that has been damaged. Now, very rarely do you ever get tissue regeneration. Certain organs can actually regenerate exactly the tissue that was there previously. For instance, the skin is very good at regenerating. Other tissues, such as the heart or the brain, they don't regenerate, and instead you just, where you've had an infective lesion, you just get scar tissue laid down there, collagen. You replace whatever was there previously with loads of collagen, because that's all that the fibroblasts can produce. They can't suddenly magic up new cardiomyocytes to replace the ones that have been destroyed. And that's why heart attacks produce permanent damage, and strokes can produce permanent damage because you can't regenerate those portions of the body, those vital organs. It always seems bizarre to me that the two most important organs of the body have the lowest regenerative capacity of any of the organs of the body, the heart and the brain. Okay, but that's another matter. So, there's the motivation for what's about to happen. Whoops, what is it doing? Yeah, I was wondering what that was over there. So, these two cells then, they're going to release lots of molecules that will stimulate the fibrosis, the scarring process, and fibrosis is just a fancy word for scarring. But the major one, if you're going to learn just one, and I like just learning one, is transforming growth factor beta. So this is the absolutely key one to know about. So this stands for transforming growth factor beta. And we will actually be discussing transforming growth factor beta a lot more later on in the video. We'll see how it's a lot more complicated than what I'm presenting at the moment. It's released in a latent form and is then released from the latent form, but at the moment don't worry about that. They secrete this hormone called transforming growth factor beta. We'll discuss it more when we want to discuss Marfan syndrome, because Marfan syndrome is believed to be caused by problems with TGF-beta signaling. Okay, and transforming growth factor beta is now going to affect fibroblasts in the area, of which we know there are loads, because all of those different layers of the valve cusp connective tissue have fibroblasts. So this is now going to work on fibroblasts. So I'll draw a fibroblast here. So here's a fibroblast, and it causes them to turn into something called a myofibroblast. Now, what is the difference then between a fibroblast and a myofibroblast? Fibroblasts are not particularly active, they're quiescent. They don't do a lot. They sit in tissue that is perfectly healthy, which has all the connective tissue it really needs, and they might release a bit from time to time, but they're not really producing huge amounts. Myofibroblasts, on the other hand, they produce a huge amount. So TGF-beta is going to cause the fibroblasts to turn into myofibroblasts, and these still look exactly the same, but they have very different properties, and the biggest property that we need to know about is the fact that they are going to chuck out connective tissue now. So these are going to start producing connective tissue. They're going to start producing extracellular matrix, collagen, and other protein fibers and carbohydrate fibers to make up new tissue. So they're going to start producing loads of connective tissue. So the activation then of fibroblasts into myofibroblasts and the production of connective tissue, this actually produces what's known as the fibrous cap around the lipid core. So going back up to this picture, we're now going to get a whole layer of connective tissue laid down around the lipid core of the lesion. So in orange here, what this is supposed to represent is connective tissue, loads and loads of thick connective tissue. New extra connective tissue is being produced there. So this is connective tissue, and this has a name. This is called the fibrous cap of the lesion here that we're producing in our valve cusp, or as I say, this is still exactly the same as what I'd be saying if we were discussing atherosclerosis, so you can view this as teaching you both atherosclerosis and calcification of the valve cusps at the same time. So the fibrous cup of the lesion, we'll say. Okay, now we've done the fibrous cap. Now it is time to discuss the calcification bit. Where does the laying down of calcium occur? And this is the sad part of the story. This is where we really don't understand something. the myofibroblasts now convert further for reasons that we don't understand. We don't understand what signaling molecules are released and who releases them that cause this, but the myofibroblasts can convert further into a new type of cell, and I don't actually know what shape to draw this in, so I'll just draw it like this, a non-committal blob here. But it converts into a type of cell known as osteoblasts. You see, I was going to go for the same shape as the myofibroblast, but then I know from previously discussing osteoblasts in other videos that osteoblasts have a different shape to this. They're not as long as the myofibroblasts, but never mind, it's a cell. Okay, so here's a non-committal blob for the osteoblast. So the myofibroblasts can convert into these osteoblasts. Now, osteoblasts are cells that you have on the surface of bone, and they are involved continuously in producing bone. The other type of cell you have on the surface of bone is osteoclasts, and they are involved in continuously breaking down bone. So all the time, your bones are in continuous dynamic equilibrium. I love that term. Where the osteoclasts are continuously breaking down bone and the osteoblasts are then continuously replacing it. And the idea is that you know, if you get bits that are damaged, the osteoclasts can break them down and the osteoblasts can replace them with a nice new bit of bone. So you're continuously repairing your bone through this process of the osteoclasts and the osteoblasts. So the osteoblasts, fundamentally, they create new bone, and we're now forming osteoblasts, wrong thing, osteoblasts in our valve cusps. So what are the osteoblasts going to do? Well, they're going to start secreting more connective tissue, specifically the connective tissue that makes up bone. So here you need to know a bit about what bone actually is. So bone is a massive connective tissue. It is fundamentally connective tissue, and it consists of loads of really ordered collagen fibers. So it's not just collagen connective tissue that you have anywhere else. It's collagen fibers lined up perfectly, basically. Loads of collagen fibers lined up absolutely perfectly, like I'm drawing here. So collagen fibers lined up absolutely perfectly, and this is what we call bone matrix. So the osteoblasts are going to start secreting bone matrix, and then they're going to start secreting the other component of bone, because of course collagen fibers just lined up beautifully like this is not bone, that's just cartilage at the moment. To turn it into bone, you need to add on to it the bone mineral, and the bone mineral is a mineral called hydroxyapatite. An ionic compound is what we mean when we say a mineral, and this is hydroxyapatite. And this consists of 10 calcium ions, so here's the actual formula for it. Calcium 10, so you've got 10 calcium ions, and remember each calcium ion is divalent, positive, so that gives us a charge of plus 20. Then we've got 6 phosphate ions, so PO4, and that has a charge of -3. So just to draw out a phosphate ion, you've got the phosphorus atom at the centre, double bound to an oxygen, and then you've got 3 single bonds to oxygens that have all acquired another electron via ionic means, and therefore all have negative charges. So this ion has a -3 charge, so you're going to have 6 of those, so that overall gives us plus 20 from the calciums, and then -18 from the phosphates, so that gives us overall 2 positive charge overall. To balance that, you then have 2 hydroxide anions, which both have a negative charge, so that takes us to neutral. So this is the formula of the ionic compound hydroxyapatite, and the osteoblasts start secreting the ionic components of this into the bone matrix, which is these collagen fibers. And basically what happens is quite complicated, but these ions integrate with the collagen, so they bind to each other. So the calcium ions will bind to the phosphate ions and the hydroxide anions because of the ionic charges. So I might just try drawing a bit of this. So here is a calcium ion, and you know it's got an ionic attraction to the negative charges on the phosphate, and they bind to each other ionically and form a beautiful ionic lattice. So they form a crystal, but they also bind to side groups on the collagen fibers. So they bind to ionic groups on the side chains of the collagen fibers. So it's very clever, basically. You've got a beautiful ionic complex, but it's also integrated into the bone matrix, and that is what bone fundamentally is. This really ordered connective tissue with this ionic crystal integrated within it. So I don't know how to draw this other than just put loads of little dots in here to show the fact that we've got all these ions bound to each other and also bound to the collagen fibers, like so, and that is what bone is. So really ordered connective tissue collagen fibers, which is the bone matrix, with the bone mineral integrated amongst it. Okay, so that's what osteoblasts do. They secrete the bone matrix and then they secrete the bone mineral so that bone will form. And that's what the osteoblasts that we are going to get in our valve cusp are going to start doing. So you actually end up with a calcified area forming underneath the lipid legion here. So this is the calcified area. Okay, and that now is the complete pathogenesis of these calcific masses on the valve cusps. This is the complete pathogenesis of calcification. So what does it overall result in? It results in these round calcified masses on the valve cusps. So let me just try and draw this. So if I draw out one of the aortic valve cusps, and remember they have this complicated shape like so. So here's one of the aortic valve cusps, like so. So the three separate walls of one of the aortic valve cusps. What you'll end up with is a great big sort of mass like this, protruding out from the valve cusp like this. And you can describe this as a round calcified mass. Okay, and these round calcified masses, of course, what they are overall going to lead to is, if you get lots of these, you can imagine that they are going to affect the movement of the valve cusp, because they're quite rigid. So if you get lots of them, especially in the bits that are effectively the joints where it's actually moving, where the valve cusp particularly moves, if you get those forming, it's going to stop the valve cusp moving properly, and that's why it no longer opens correctly, and why this calcification process, the formation of these round calcified masses on the cusps of a valve, will lead to the stenosis of that valve. Now, aortic stenosis, due to this calcification process, typically occurs, or typically starts to actually produce symptoms in the 7th to 9th decades of life. So a little extra fact about this. So 7th to 9th decades is when generally the stenosis actually becomes apparent. Of course, the pathogenesis process will have been occurring for years and years and years, but it's only in the 7th to 9th decades that you've got enough of these calcific lesions on your aortic valve cusps that it produces significant enough stenosis of the aortic valve for it to actually produce symptoms, and you go to your doctor and then they actually diagnose you with calcific aortic stenosis. So it typically presents in the 7th to 9th decade. There is an exception to that, because there is a quite common, what's the right word, different type of aortic valve that people can have. Okay, there's something called a bicuspid aortic valve, which for short is abbreviated down to BAV, and this is actually extremely common. So a lot of people do, variant is the word I was looking for. So this is quite a common variation of the aortic valve. So we have described the anatomy of the aortic valve having those three cusps, the right, left, and posterior cusp. That is the normal anatomy. That's what most people have. However, there is a quite common variation of that where you, instead of having three cusps, you have two cusps, and this is called bicuspid aortic valve, or BAV for short. And this is actually present in 1% of the population. So 1 in 100 people will not have an aortic valve with three cusps, and instead will have an aortic valve with two cusps. And generally, if you have a bicuspid aortic valve, usually one of the valves is much bigger than the other. So it's almost as though one of the cusps is much bigger than the other. So it's almost as though two cusps have just not separated from one another. So it might look like this. So these are the two cusps one here, one here. And usually you end up with like a midline raphe through the larger one. So a division, an obvious division where they should have separated, basically. So this is a midline raphe, but for whatever reason in development they didn't separate. So this is the normal form of bicuspid aortic valve, where one of the cusps is much larger than the other and has a midline raphe. Raphe just means division. So an obvious point along the midline where it should have separated into two separate cusps, but it hasn't done for some reason during development. And that's the common form of bicuspid aortic valve. However, some people actually do have an aortic valve where you do just have two separate cusps of exactly the same size, like so. So why am I even bringing this up? Well, the reason that I'm bringing this up is that if you have bicuspid aortic valve, you are much, much more likely to develop calcific aortic stenosis, and you generally develop it earlier on in life than if you don't have bicuspid aortic valve. So people with bicuspid aortic valve generally develop calcific aortic stenosis in the 5th to 7th decades of life, and not only are they going to develop it earlier, but they're much more likely to develop it than people with the normal anatomy of the aortic valve. So, why is that? Well, it's because a bicuspid aortic valve is not as good as a tricuspid aortic valve, I'm afraid. If you have this, it generally means that the strain on the endothelial cells covering these cusps is going to be greater. You can imagine that if you've just got two cusps like this, it's going to be more difficult for this to open properly and allow blood out from the left ventricle into the aorta, and therefore you're going to be getting more strain on the endothelial cells, and therefore calcification generally occurs quicker. Also, you've got the fact that this actually, it didn't ever open as well, potentially, as the tricuspid aortic valve initially. So further damage to it opening correctly is going to lead to noticeable stenosis that will produce symptoms quicker than if you had had the tricuspid aortic valve. So summarising then, if you have this bicuspid aortic valve, which indeed 1% of the population do, and there are these two different ways that it can occur, either one cusp can be larger than the other, and then it generally has a midline raphe in it where it should have split. Occasionally, very rarely, people have two cusps of exactly the same size. This makes you much more likely to develop calcific aortic stenosis, the reason being that these valves are going to experience much more strain than the tricuspid valve, and that's the whole thing that sets off the pathogenesis anyway. So you're much more likely to develop it, and if you do develop it, you generally develop it earlier, so in the 5th to 7th decades rather than the 7th to 9th decades. Okay, right, so that is the calcification process then. We will have a break here, and in the next video we'll discuss rheumatic heart disease.